What's good, everybody? This is Daniel. Here for a video on hypertrophic obstructive cardiomyopathy, also known as HOCM. Um, and yeah, I feel like this is an important and very tested concept on step one and other MBME exams. So I thought it would be a good idea for me to go over that. Okay. So, quick overview. So HOCM is a genetic heart disease characterized by asymmetric thickening of the interventricular septum, a small left ventricular cavity, and most importantly, dynamic obstruction of blood leaving the heart. And this is not just a thick heart, it's a heart that blocks its own outflow, especially under certain conditions. So, you can kind of think of HOCM as hypertrophy plus obstruction that changes with preload. And you're gonna see hokum most commonly in a young person. Like it doesn't have to be an athlete, but I feel like a lot of the questions does mention like, oh, it's a young athlete who suddenly just dies, and you kind of like can infer that they're talking about hokum. I feel like the most important thing from this slide is definitely the asymmetric septal hypertrophy. I feel like that's something that you should definitely know. Um, and the young person, like the death in a young person, is pretty relevant as well because it kind of leads you to hokum. And I just wanted to mention about the harsh decrescendo systolic murmur. It's best heard at the left sternal border. Um, and so it's due to a narrow outflow tract due to the thickened septum, which narrows the left ventricular outflow tract. And then this increases the velocity. The blood speeds up as it exits the ventricle. And then the Venturi effect happens, which is when fast moving blood pulls the mitral valve anteriorly toward the septum. I think you should know that the mitral valve is pulled up anteriorly toward the septum. And this is also known as the systolic anterior motion, or SAM, of the mitral valve. And the worsening obstruction is caused by SAM further blocking the outflow tract, which increases the turbulence. And this causes a harsh systolic murmur with a crescendo decrescendo pattern, which is best heard at the left sternal border. Okay, so as for the pathophys, so HOCM is usually caused by an autosomal dominant mutation in sarcomere proteins, most commonly the beta myosin heavy chain. And that is pretty important to know. I think the only other one that is relevant is probably like dilated cardiomyopathy, which is also can be caused by an autosomal dominant mutation, but it's definitely not the beta myosin heavy chain. And these mutations in HOCM leads to abnormally thick cardiac muscle cells, disorganized myofibers, and increased myocardial stiffness. So I think from here you should definitely remember the disorganized myofibers, because I feel like that detail comes up on a lot of exams. Like, I don't know why. This is just like something that they like to test you on. And okay, so what does the stiffness do? What does the increased myocardial stiffness do? So, a stiff ventricle, it can't relax well, and so this impairs diastolic filling, which raises the left ventricular filling pressures. And that's why patients with HOCM usually have dyspnea, chest pain, syncope, or even have sudden cardiac death. So, yeah, so from this slide, probably the most important thing is the disorganized myofibers. Okay, hemodynamics. So in HOCM, the left ventricular cavity is small. The septum bulges into the outflow tract, and the blood must squeeze through a narrow passage. And as blood accelerates through this narrowed area, that's kind of why you have like this problem, right? And so, yeah, like we discussed, the left ventricular cavity size is decreased because you have this asymmetric septal hypertrophy that's pretty much taking space in the left ventricular cavity. And I already talked about how diastolic filling is impaired and the rest. And yeah, it's very preload dependent. That's why the murmurs are very dependent on the maneuvers. So yeah, so Valsalva, it increases the murmur because Valsalva decreases the venous return, which means your preload decreases, and that means your left ventricular cavity decreases even further than what it is now due to Hocum. So if you have a smaller cavity or a smaller left ventricular cavity, then you have even greater obstruction, and that's why the murmur gets louder. And the concept is the same for standing. When you stand, your venous return decreases, your preload decreases, and again, it shrinks the left ventricular cavity size again, therefore increasing the murmur. So Valsalva in standing decreases preload, and then increases the murmur in Hocum. As for squatting, so squatting actually increases venous return and increases preload, which causes the left ventricular cavity to expand, and this leads to less obstruction, which softens the murmur. So, and hand grip, in hand grip, it increases afterload, which slows ejection velocity and which reduces the Venturi effect, which I mentioned was the fast moving blood, which pulls the mitral valve anteriorly toward the septum. And so the less, the less systolic anterior motion of the mitral valve, the softer the murmur. So yeah, just think of it as, okay, increase in preload, or sorry, yeah, no, decrease in preload increases the murmur, and then a decrease in preload, an increase in preload causes a decrease in murmur. Yeah, I know this murmur stuff is so confusing sometimes, but I feel like if you like kind of sit down and think about it, it makes sense. Like I was mentioning, like Valsalva and standing, it decreases venous return, right? And so because it makes sense. So it decreases venous return, and therefore you have decreased preload, and that's why your left ventricular cavity decreases in size, which causes an increase in the obstruction. So yeah, it makes sense once you kind of like think about it. And I feel like just like know what these maneuvers even do in the first place. I think you can get all of the questions right. Like if the question comes up and it's like ASD or VSD or whatever. But yeah, for Hocum it's a little bit different. So yeah, so this is a sample question. So just take a minute to kind of take a minute to kind of try to answer this on your own. And then I'll just go over it in 5 seconds. So 5, 4, 3, 2, 1. Okay. So the answer is going to be B, and it's because this patient has hypertrophic obstruction cardi. This patient has Hocum, obviously, and as I mentioned, standing makes the murmur louder because standing decreases the venous return, which decreases the preload, which causes a smaller left ventricular cavity, and a smaller left ventricular cavity causes a worse left ventricular outflow tract obstruction, which causes an increase in turbulent flow, causing a louder systolic murmur. So, and I think, I guess it would be good to kind of go over how to answer this question properly. So you want to read the last sentence first, read the last sentence first. So which of the following best explains the change in murmur intensity observed with standing? Read that first, so you kind of know what the question is even asking you, right? You're looking for what explains the change in murmur intensity observed with standing. Okay, so you already know that standing will cause a decrease in preload. And so you're kind of like, okay, you just keep that in mind. And I know some people like to read the question, like the answers right after, but I feel like my brain isn't too big to remember what the answers are. So I just read the question. So a 19-year-old male college athlete collapses during basketball practice and briefly loses consciousness. So talking about a pretty young athlete, and he kind of collapses. So that's kind of like pretty classic hokum. He has no prior medical history. His father died suddenly at age 42. So this kind of shows you that there's like some family, like what is it called? Like genetics involved. And physical examination reveals a harsh systolic murmur best heard along the left sternal border. So that's pretty, it's kind of basic. I feel like this doesn't, like, at least, like, it doesn't, like, point you directly to hokum, but I feel like it does align with hokum. You know what I mean? And then the murmur increases intensity when the patient stands from a squatting position and decreases with sustained hand grip. Okay, so I feel like this line, it should give you the answer that this is definitely hokum, right? And echocardiography shows asymmetric thickening of the interventricular septum with systolic anterior motion of the mitral valve. Okay, yeah, and this also like kind of gives you the answer. And unfortunately, MBME is not going to be as nice as I am. And they're probably only going to give you one or the other. And the wording can also be very different. And yeah, the answer has to be B. B is the only one that makes sense because it literally talks about what standing does, right? Which decreases venous return, resulting in reduced left ventricular cavity size. That's what standing will do, along with Valsalva, right? So that's pretty easy. And then so if you are a visual person, I'm not really a visual person, but I just wanted to include like some type of images. I feel like this picture is like a good summary of everything that we just discussed. It kind of has everything. It has like the family history. It has like the picture. It has the murmurs, and it also has like the treatment as well. So that's pretty good. And then this one, I just got it online. It just kind of shows you the asymmetric thickened ventricular, the interventricular septum. So you can kind of see that the cavity size is a lot smaller here. And then treatment. So I don't know if you really need to know this because I've never seen it before, but I guess it's just good to know. Beta blockers and non-DHB calcium channel blockers will help. But yeah, I mean, like, beta blockers, it will slow the heart rate, which allows for an increased diastolic filling time, which can reduce the obstruction, right? Because you have more preload, right? And the non-DHP calcium channel blockers is pretty much the same. It just improves the filling, which will again reduce the obstruction. I don't think I've ever seen like the drugs being discussed, but yeah, just remember the key things to remember. I feel like is definitely the young athlete who kind of like has like some type of he's either dead or he like something like faints. Some type of family history, and the harsh crescendo, decrescendo, systolic murmur. I feel like that's pretty important as well. There is also an S4 gallop due to the stiff ventricle, right? So you should probably know that, but it's not as important. And yeah, definitely know the asymmetric septal hypertrophy with the systolic anterior motion of the mitral valve, right? This is very important as well. And you're also going to have a pretty normal to increase ejection fraction, but to be honest, I've never been tested on this before, on the ejection fraction. That's kind of why I didn't really talk about it, even though still could be on it, but I've never seen it before. So, well, that's pretty much it. I hope you guys enjoyed it. and this is like my first time making this type of video, so please leave a comment on, like, give me a feedback, because I love constructive criticism. Yeah, I had a lot of fun making this video. Sorry if I'm like not the most cheerio type of person. It's just my normal voice. But yeah, cool. I appreciate everybody watching. I'm gonna try to keep dropping videos. Because I have some downtime right now. But yeah, just give me some feedback, like and subscribe. Appreciate it. Thank you. Bye bye.